many things are fundable. The standard, it's competitive. There is not enough money to do the research that's worth doing. So it's not just about having a good question and putting on a good show. You've got to put on a damn good show.
Welcome to Season 2 of the sOOPR podcast. In these conversations, we're bringing you even more insights from successful fellows and advice from leaders from across the UK research landscape. I'm Nikhil Alawalia, and this is brought to you by the British Junior Cardiologists Association in partnership with the BHF CRC. If you like these videos, please subscribe to our YouTube channel and leave your comments below. I'm pleased today to be joined by Professor Matt Sydes, who's Professor of Clinical Trials and Methodology at the MRC Clinical Trials Unit at University College London. He also leads the Data-Enabled Trials team for the BHF Data Science Centre. Professor Sydes is also on the Executive Committee for the NIHR MRC Trials Methodology Research Partnership, as well as serving on several research funding panels. So we're really lucky to have him here today with us to share his perspective and advice. So thanks for joining us, Professor Sydes.
Thank you for speaking to me today.
So the first thing I often ask the guests is to tell us a little bit about their journey into academia, in particular, any notable moments in your career that really took you down the academic and research path.
Yeah, okay, thank you. I guess my journey was not necessarily a straightforward one, but no one's journey is really, I don't think. So I'm a statistician by background these days, and that's what I've been primarily working as. But I started work as a clinical trial manager back at the MRC Cancer Trials office in 1995 when I was still a little boy in short trousers. But working in the Cancer Trials office, I really got to see and learn about clinical trials and was absolutely fascinated. I sort of quite enjoyed maths at school, but I absolutely despised statistics at A level. Just couldn't quite get to grips with it. But here it was being used, and I could see what the statisticians were doing. I could see how the data were being used, and from there, moving across into a stats role within the unit, and then working my way up through the senior staff. And then we became part of UCL in 2013 as part of the MRC's rearrangements of how its units were formed. So I ran clinical trials. I was lucky enough to be involved in, first as trial manager, then as a statistician in a number of clinical trials. We're a trials unit that does methodology, though the MRC sometimes sees us as a methodology unit that does trials. It's really about how do we design, conduct, analyze, and meta-analyze clinical trials better. And then about 6 months ago, I joined BHF Data Science Centre on a 20% secondment to lead their data-enabled trials work, because real-world data, electronic health records for clinical trials is one of those areas that I think has the opportunity to change the way that we design and deliver clinical trials going forward. So a particularly interesting area for me, already involved in Health Data Research UK, and really feel there's an opportunity to help the cardiovascular world that's ahead of the game in many ways to further take leadership here.
So you had a lot of experience evaluating studies, proposals, and sat on funding panels. Can I ask what stands out to you as a good trial design and that you recognize as a study that's worth supporting? And conversely, what do you often see in poorly designed studies that need some more work to go forwards?
Yeah, it's a really good question. So funding panels for clinical trials, what you're looking for is a plausible question, a realistic question. So one that's going to ask a clinically important question that's achievable, that's got they've picked the right outcome measure, they've picked a realistic effect that they might look for, not too ambitious, not so small that it's uninteresting, that it's not going to move the field forward, that's achievable in a deliverable timescale, and for which the funding is realistic, and for which they're going to be able to recruit people. We know that still the biggest problem for clinical trials is that they don't recruit. Identifying people out there and recruiting patients is very difficult. It's a lot of time and effort required to do so. I mean, it's one of the reasons why I think NHS Digital at NHSX has really been looking at the find, recruit, follow work. I'm particularly interested in the follow. We'll come back to that, I'm sure. But the find element is really important. And if you're looking for, I mean, what does that mean? If you're looking for patients newly diagnosed with a treatment or relapsing, with a sort of a new healthcare condition, a new phenomic state that they're in, if I can use that term, then you know where to find those. They're in clinic, right? They come to you. You've got a new cancer diagnosis. If you've had a heart attack, if you just had a stroke, you're in the hospital. We know where to find the people for those questions, right? And so, what you've got to do is find out if the question maybe is being sure you know which are the research active units, which are the ones who are research active and good at giving you the data, who are reliable in being able to do this, or the ones that give you the diversity that you need, your diversity and all the things in which we're looking for, broad representativeness in the population that you're trying to recruit. But if you're looking for sort of a prevalence case population, if you're looking to recruit people who are living post-MI or living, people who've had an implanted defibrillator and you want to look at a certain thing, if you're looking for people who are on a particular treatment and you're long-term and you're looking to manage their side effects, then where are they? Well, they're probably not pitching up in your hospital clinic so often. They're probably out in the wild in general practice. And there's a whole stack of questions we want to ask in those patients, right? There's a whole stack of questions you want to ask where we can really improve outcomes. They're much more difficult to pin down. And so I would argue there that the find and recruit service that NHS Digital NHSX is looking at could be really valuable in that instance in being able to identify and approach people, because we need to be able to recruit. You've got to be able to recruit to your trials. So you were asking about funding. I've meandered because I'm rambling the whole time. That's what I do with these things. Please forgive me. Looking for an achievable question. Do I believe that they can actually recruit? Do I believe that they can get an answer? Is it going to be a good answer? Is somebody else already answering this question? Or has it been answered already? And if they think it's going to take 5 years to get an answer, if they think it's going to take 2 or 10 years, is the question still going to be relevant at that point? Because if it's not going to be relevant, there's no point in answering the question. My experience of sitting on funding bodies, many things are fundable. The standard, it's competitive. There is not enough money to do the research that's worth doing. And so many things score in the fundable, but don't get funded approach. So it's not just about having a good question and putting on a good show. You've got to put on a damn good show, and you've got to really tick the boxes, and you've also got to show that you can do the things around this. It's a modern world. You've got to be able to show how you can do data sharing at the end. You've got to say, how are you going to consent patients and what role have they had in developing this? I want to see, how are you going to get the findings for your study back to the participants? How are they and their families going to know what happened? And HR is going to push on that much more. The results of Show Respect that came out 20 for 21 is really pushing this. Getting results back to the participants who've given up their time and effort is really important. So these are the kind of, the brownie points, the bells and whistles. They're not bells and whistles. They're high quality fundamentals. And that's the sort of thing that we'd be looking for, I think.
Great. And from your experience, for someone, say, who wants to go down to an academic path and have that alongside their clinical work, do you think that there are additional values, perhaps, of not necessarily running your own study, but actually becoming a member of a larger team and supporting a much bigger study, say?
I mean, if you're involved in a bigger team, in a bigger piece of research, then there will be more issues for you to be exposed to. So there's more chances for, should we say, interesting things to happen from which you will learn lessons. So absolutely, I think if you're part of a bigger project, bigger team, there's more lessons, and actually there's more chance that what you do together is going to have practice-changing impact in some form than anything else. You will, of course, be a smaller cog in a bigger machine, and academia still does like it when people have been front and center, and that can be quite difficult. I think credit and recognition for trial team members is not what it should be in clinical trials. And if there's somebody listening that is particularly interested in working with me in that area, I really want to, there's a PhD proposal in my mind for which I need to find funding, but you can't apply for funding till I know who the person is. So if there's someone keen to be able to think about credit and recognition with me, you know how to get in touch at the end of this, right? So
Great. It'd be great if someone takes you up on that.
that would be brilliant. That would be really good. So, if you're thinking about your career, very often a small paper on which you're first author goes a longer way than being somewhere in the middle of a practice-changing paper, right? And I think that should be necessarily the way. Some people who are academically minded, leaders of the future, they very much are, you're the individuals who want to be leading from the very outset. They know front and center, it's in their mind, they know what they want to do. We'll do it my way, we'll build on small projects and they'll build up. And that's great. And that is one form of leadership. That's what leadership looks like to a lot of people. Actually, you're taking your time, participating in, contributing to, moving things forward in that team approach is another form of leadership. It doesn't always get recognized in quite that way, but I think it's a really important way of doing things. And in lab-based work, that pyramidal model is much more obvious. And many clinical people will want to go down PhDs in clinical work for that reason. Clinical trials are much more collaborative. It is a cloud of people doing work together. And some people will take more responsibility, will have more responsibility to need to be taken than others. But there's always bits that people will need to be able to drive forward and need to be recognized for.
Great. So, given your experience with electronic health records, I really do want to ask a bit about how we can do that better. You may be aware that in junior doctor training, we have emphasis to do audits and quality improvement projects, and very often that becomes a quick trawl and search of electronic health records. And I think that's probably why it's disregarded. And I think the emphasis on big data and what we're seeing happening with groups like the Biobank studies really bringing electronic health records back into vogue. I was wondering if you could potentially comment on where you think the exciting areas are on EHR research.
Yeah, okay. So I think electronic health records and greater use of information has an opportunity to transform the way that we do clinical trials. At the moment, if we taking data from trials, then you put a patient into a trial, your team writes down the data about that patient on a paper copy. Maybe there's some typos, maybe we can't read it. It gets sent through to a trials unit. Somebody transcribes it onto a database. It's this duplication of effort there, isn't there? You've also put the data into the hospital system. You've been recording it in the hospital or the primary care system, wherever you are. Wouldn't it be better if we could take the data directly out of those hospital record systems, whether that's at the hospital level or even better in a broad and deep national electronic health record system, and take the relevant information directly out of healthcare systems data and into the trial data set. So, which means that the cost of trials should be less. And then we can get more trials done for the same amount. And if we look at that scoring that we talked about just now, more of the things that are in the fundable range but didn't get the funding should be funded. So we get more trials done in the same envelope. So we need to push for more data to be into those systems, or we need a simple way to get the data out of electronic health systems and directly into trial systems.
Do you have an idea of, I mean, it's an impossible question, but do you have an idea of timeline here? I ask because I remember back in my sort of specialty interviews in my training, and they said, what do you see as the future for the NHS in 5, 10 years? And I said something along these lines of a unified record system to be able to do research on a national level. How far away do you think we are from being able to do sort of national level EHR based research?
Yeah, if we can find some way of drawing data collators together and talking, can we find a way to facilitate this for trials? That would be great, wouldn't it? And I think it's that discussion, it's finding a way, even if we could move towards having one trusted research environment in which we were allowed to go that then was able to reach the data. We could reach the data that's in Scotland and use that data. It can reach out the data that's in Northern Ireland and use that, but it stays where it is, reaches the data through. Health Data Research UK is really interested in trusted research environments. Other groups are, it's beyond my sort of skill set to get into the details, but that's potentially a hopeful approach there. The concern for TREs for me for clinical trials is the sponsor has a responsibility to know what the data are and to hold that data and to archive a copy of that data according to the regulations, which could be 25, 30 years as the regulations change. So, if the data is in somebody else's trusted research environment, all I'm doing is reaching out to it. We've got to be really sure that somebody else doesn't delete it or edit it. And how do we really show that the sponsor has discharged their responsibilities in that way appropriately? I'm a little bit anxious about that. And I think that's one of the challenges we need to address.
I think original data collection takes a lot of time. And so for fellows who maybe have 2 or 3 years, these sort of opportunities of data that's collected that then just needs to be curated and analyzed is potentially a much more feasible project to get really meaningful results out of. And so do you think that's a good opportunity for fellows who perhaps have a question that they want to answer, that they can look to these sort of larger data sets?
I think it is. Or it may even be that what you end up doing is impressing someone with your question that draws you into conversation where you end up doing something different and something achievable, but that still gets you to a good place, right? May I just sort of pick up on the NIHR Associate PI scheme? This is really an opportunity to get some credit and recognition for some of the particularly career young people who are spending maybe a small amount of time working on a clinical trial, mostly at a site. But this is a way of getting some sort of formality within that, and I think that's really helpful. I'm delighted they do that scheme.
So now I'm thinking of any final messages that you may have for any fellows who are thinking about doing research but don't have a project to hand but may have a good question. What would you advise to them?
There's lots of really good questions out there. If you don't have your own question, have the breadth of a question, an area in which you want to research. There are plenty of clinical folk out there, plenty of trials unit folk out there who've got questions that they want answering, and they need people to work with them. So you don't necessarily have to have all of the ideas to get your study to run. You don't need to know all of the details. If you've got a principle, find someone, start to talk to people. Show that interest in research. I think my sense is for the majority of people who engage in research, it's a rewarding experience, even if what you end up doing is you spending your time in the future as a jobbing clinician who facilitates a bit of research. That is super helpful for the community. Not everybody can be leading clinical trials all the time. We want a research aware clinical community that knows how to do research, even if they're not looking to be leading on things at consultant level overall, that are willing to set up decent systems, that are willing to have associate principal investigators at their site who can actually facilitate getting practice changing research done. So if anyone's thinking about research and they're torn between the lab and clinical trials based stuff, then actually, I would always encourage people to think about that clinical work. It's I know the lab-based work can often feel like, well, that's mine and it's achievable and I can do that. Actually, the trials unit world will always welcome you. There's always questions to be addressed, and and if you're even thinking about research, you're in a good place. Keep going. Thank you. You really appreciate everything.
I think you've left people with the clear idea of how exciting an opportunity now is for clinical trials research. And is a whole network of clinical trials units across the country which people can reach out to that's local to them. So thank you so much, Professor Sydes, for talking to us about that. Thank you.